2 minutes time.
Ma'am, you are going to be the candidate, ma'am.
Yes.
Ma'am, should I ask you to summarize, ma'am, or I have to go to first question?
Two question. Any question you can ask about accordingly.
Okay.
Last 20 seconds. Started my 10 minutes. Hello. Hello, I'm Dr. Prajakta. I'm one of the part 3 candidate. I'm ready for structured discussion. I have gone through the scenario.
Okay. Have you gone through the scenario? Can you summarize?
In this case, I'm suspecting a bladder injury in case of previous two elective case for cesarean section with previous to cesarean section. So anticipated high risk factor for bladder injury are previous to C-section and high BMI. So I'm anticipating a bladder injury in view of clear fluid visible while separating the bladder.
Okay. Now, what immediate action will you take?
Okay. If I'm suspecting a bladder injury, my first action will be to confirm the bladder injury and not to proceed further. So here onwards, I would like to stop the procedure and call for help and confirmation of the injury will be my next action. So call for help will be, I will be explaining to the anesthetist and in a non-frightening way to the patient also that anticipating a suspected bladder injury needs confirmation. Extra time, extra instrumentation and extra procedure might be needed in her care, so it take a longer time, so the anesthetist will prepare for extra IV line, extra dose of antibiotics, IV fluids, and may collect some baseline blood investigations including full blood count, urea electrolyte, and blood cross match if need arises. I will call upon my consultant and will involve him in further care. Also, would like to involve the scrub nurse to arrange a trolley as early as possible for extra instruments. Meanwhile, I would like to confirm the injury by either injecting methylene blue through Foley's catheter and will assess the extent, site, and size of the injury. If possible, consultant will be available and around. We can also take a help of cystoscopy here also for confirmation of the injury.
Uh, what is your approach to the completion of operation?
Yeah. So my approach to completion of surgery will be if it is feasible and it will be it will not be difficult, then without causing further damage to the bladder, I would like to continue with the elective C-section and deliver the baby safely, hand it over to the pediatrician for further care. uh, Meanwhile, my consultant will join me and then we will confirm size, site, and the extent of injury. Depending upon the size, site, and proximity to the ureter or trigonal area, my consultant will decide whether we need to suture, he will be able to suture the injury by following the principles of bladder suturing, or he needs to involve the urologist here. If it is nearer to the ureter, then there might be stenting needed, and urologist will be involved in her care. If not, then a consultant can go ahead with the suturing. The principles of bladder injury suturing will be followed. 2 or 3 polygalactic sutures will be used. Non-interlocking, 0.5 to 1 centimeter apart. Ensure that it will be leak-proof, watertight suturing. Two-layer, double-layer suturing will be done here. If it is a small defect, then it can be sutured with figure of 8 sutures also. Uh, then there will be continuous catheterization for 2 weeks with intraperitoneal drain, and the remaining procedure of C-section will be continued and will be completed by uterine closure, and WHO safety checklist will be followed. Ensure swab mop count will be there, and baby surgery will be completed. That will be my approach to
Completion of operation.
procedure.
Okay.
Yeah.
Now we come to the third question. What is your post-operative management plan for the patient?
Okay. So my post-operative management plan will be immediate, and then after some time. Okay. So the immediate plan will be completion of the surgery. It will be documentation, proper documentation, writing down the OT notes, uh, writing down the post-operative orders, especially regarding the catheter care, and instructions to the midwife or the post-operative nurse to take up ensure that the catheter care will be monitored. Extra dose of antibiotics, and continue IV antibiotics for 7 to 10 days. Mm, VT assessment is very important in this case. Assess and accordingly low molecular weight heparin if it is needed in this case. Prolonged surgery, high BMI. So accordingly, we can continue that. Adequate pain relief, hydration, early mobilization will be encouraged in these patients. This is my immediate post-operative plan. Once the patient has started mobilizing, started tolerating orals, and passes open the bowels, then we can discuss. We can shift this patient to the ward, and where we need to discuss the implication of bladder injury, uh, prolonged catheterization, continuous antibiotics. Discharge will be discussed with the patient. Along with that, neonatal care, breastfeeding, contraception will be discussed with the patient. Discharge will be discussed to the GP surgery, and the catheter care will be also discussed with the continence nurse specialist in the GP surgery. Clinical governance part will be here. So incident reporting, documentation, debriefing, duty of candor. Uh, this will be offered to the patient, and if need arises, we can also continue with the root cause analysis in this case. So these are my
Fourth question is there. What
yeah.
issues would you discuss with your patient? This partly you have explained now itself.
Okay, so post-operatively, my discussion with the patients, I would like to be open and honest with the patient. Would like to apologize for the unfortunate event what has happened with the patient. It's a known rare complications of surgery, cesarean section. In case of high risk cesarean section, like previous to LSCS. So I would like to offer her duty of candor. Would like to explain her the implication of this injury. That means a prolonged hospital stay, prolonged catheterization, prolonged antibiotics. She needs to continue. In rare cases, if it will not heal, then the chances of having a vesicovaginal fistula, which might be needs to be repaired in subsequent days. Uh, Catheter care, continence nurse, GP will be involved in her care. Once she will be fit to go home, she will be discharged home, where breastfeeding, contraception, and newborn care will be discussed with the patient at that time. And whatever investigation will be coming up, we will discuss the investigation of the root cause analysis with the patient by the senior consultant. So this will be my uh, discussion with the post patient.
When will you ask her to come for follow-up?
Yeah. Here I will also like to tell the patient regarding the red flags when she needs to report to the emergency with 24-hour contact details. Any fever, any leakage, any vaginal discharge, any excessive bleeding, or otherwise she can report to the to the routine care after 2 weeks with continuous catheterization. If there will no leak on retrograde cystourethropy, then the catheter can be removed. If there will be leak, then extra catheterization for 1 week can be offered to this patient. Patient will be given a patient information leaflet regarding the injury, and patient will be offered all support and care during this time.
Is the time still, ma'am?
Last 1 minute 40 seconds. Any question would you like to ask?
So what are the complications you expect in her condition?
Yeah, so in this case, since it's a prolonged surgery, there might be a anticipated risk of infection, injury is there. So that is one complication. Infection, some bleeding, extra bleeding might happen because of the prolonged surgery. Uh, means it might be painful for the patients also because of the prolonged surgery. So extra dose of antibiotics, extra dose of pain relief will be offered to the patient. This will be immediate complications. And the long-term complication, if the bladder injury doesn't heal, then the chances of having a VVF is there. That is a remote complication of this injury.
When will you remove the? You said about intraperitoneal catheter. When will you remove that?
Stent catheter. The catheter, intraperitoneal catheter, it is ureteric catheter or the
You told
drain.
intraperitoneal drain. Sorry, drain,
Drain.
ma'am.
Yeah, once after it can be removed once the drain fluid will be less than 20 or 30 cc. Most probably we should be removed it within 48 to 72 hours as early as possible
Thank you,
in
ma'am.
this case.
Thank you, ma'am. That's all, ma'am. Super, ma'am.
Last 10 seconds.
Okay. If the injury is close to the ureter, the urologist may take over, and there may be a
He will be.
placing of a stent may be there in addition, ma'am. If the ureteric
Yes.
stent is kept, when that will be removed?
Yeah, that I do not remember exactly. Can you just keep a light on that? I cannot remember exactly when the stent will be removed.
It will be removed after say 6 to 12 weeks. As
Yeah,
per
that
the
is.
neurologist advice. I don't think 6 or 12. I also don't remember. Thank you.
Yeah, even I don't
Just
remember.
I
So I
wanted
don't
to
have
know
it.
from you. Thank you.
Yeah, no, I don't remember. We will discuss in case of VVF. That slides might be having this
Okay.
discussion. Okay, so
Thank you for
everybody
the
got.
opportunity, ma'am.
Thank you, ma'am. Thank you for me giving me opportunity to present to you, because see, structure discussion is basically in all in this line only.
Yeah.
Whenever the structure discussion will be there, if your approach will be more and more structured, you will score more and more marks, and
Yes, ma'am.
chances of scoring will be very high, very high.
Yeah, as a feedback, I'm telling you, are presenting as the SBAR, ma'am. You told that it is a suspected bladder injury. Everything you presented in the SBAR pattern, and also you told about the stopping the procedure, calling for help, informing anesthetist to prolong the anesthesia, as well as to give antibiotics after checking allergy, and informing the patient also. Everything was fine. This is a model. Now itself we are given the answer key itself.
Yeah, we will discuss the answer key, but would like to take a feedback. See, even if I know the answer key, many a times I tend to forget some things. It is humanly not possible to confirm. Means even if you
Yeah.
know the task, not humanly possible to reproduce all 100%, 100 points, whatever
Yes.
has been mentioned. So we all needs to know it's a human error, but see to it that major points which needs to be covered needs to be covered. Something like stopping a procedure, calling for help, extra help what we need to call. So this all needs to be mentioned here. I might have missed 1 or 2 points, but then the
No.
major point should not have been missed. What my
And about you
that.
told about the instrument counts,
Yeah,
everything you
yeah,
told. Yes,
yeah,
documentation, debriefing, everything you told.
yeah,
Apologizing to the patient. That is it. That's what you told.
yeah.
Thank
So let's go through the answer key. Okay, so my first answer is after introduction, that S bar tool. So situation here is a suspected bladder injury because the patient is high risk because of previous to C-section and BMI is also very high. So that is one thing. So S bar tool assessment and recommendation will go hand in hand. So here assessment will be to assess the site, size and extent after confirming the injury and repair by expert. So repair will not be by you, it will be by consultant or by urologist. So the anticipated complication of LSS literature rate quoting is 0.1%. This is knowledge basically. If you can say, you can say. If you can remove, if you can avoid, you can avoid. Okay. Stopping the procedure. Just wait, okay? I will be taking a call. Hello? Hmm? जा ना घरी. तुम्ही डीमार्ट नाहर, डीमार्ट नाहर. डीमार्ट नाहर, डीमार्टच्या जवळ, चांदिवली. हम्म. मी ऍड्रेस पाठवते, मेसेज करते तुम्हाला. Okay. So just wait. So after anticipating anti means after quoting the incidents literature quoting 0.1%, what is your immediate action? So the question comes first is stopping out the procedure and calling for help. The next line will be confirmation of injury after calling for help. So whom you are going to call? Okay, so calling for help and confirmation can be done by visualizing Foley bulb, which I had missed out. Methylene blue I had mentioned, by retrograde dye filling. IV dye, IVP also means you can also go for intravenous dye also after checking allergy to the dye, and if needed cystoscopy. So here I forgot to mention about Foley bulb and intravenous dye. But this can be performed after baby delivery. That also we can mention here. So these 3 points I had mentioned missed out. Mm, Antibiotics, prophylactic antibiotics is example I had mentioned here. Gentamicin, that is an antibiotic of choice whenever we are anticipating a bladder injury. 3 milligram per kg body weight. Then a person to be called will be informed the anesthetist in suspected injury may delay the surgery, necessary baseline blood investigation, full blood count, RFT, electrolytes, extra antibiotics and VT assessment risk calculation. Consultant for immediate act management, scrub nurse to prepare extra trolley, extra instrument. Uh, Theater coordinator for coordinating with all. So coordinator also I forgot to mention. Urologist after consultant opinion, this you can involve here also, or you whenever you are going to repair after consultations confirmation of the by the consultant, we can involve the urologist. Inform the patient in a non-frightening way, it to and to partner also if he is present. So this is my question answer to question number 1. What is your approach to complete the operation? So if we can able to identify the bladder injury and possible to separate a plane between LUS and bladder, it will be safe to deliver a baby, so may proceed with baby delivery. After baby delivery, confirm site, size, extent of injury and proximity to ureter. If so, call urologist. Bladder repair by consultant and follow principles of bladder repair. So these are the principles of bladder repair. You have to explain here only bladder repair principles. Otherwise, you will not get time to explain these bladder repair principles, and you will not get marks in applied clinical knowledge domain if you will not mention these points. Suturing either one or two, single layer or double layer, mostly double layer, non-locked, 0.5 to 1 centimeter apart from the angles of cystotomy. Figure of 8 suture if the small defect will be there. Trigonal injuries and ureteric injuries to be repaired by urologist. Ureteral stents must be inserted if ureteric injury and confirm the patency. Debridement before repair if it is a thermal injury. Injury that pierces the bladder through. These are extra points what I had mentioned, but in this case it is not important because it was not a thermal injury, and it is not a space of Ritzius injury. Okay, so if there will be an injury in the space of Ritzius, so indwelling catheter managed conservatively, can a small injury can be managed conservatively. Only thing, indwelling catheter for 2 weeks. These are the additional point which I had mentioned here, not needed to be mentioned in our scenario. Bladder repair should be watertight and leak proof. This is very important. Drain in peritoneum, continuous postoperative bladder catheterization for 2 weeks. Confirm leak prior to catheter removal by retrograde cystoscopy. Okay. If contrast escape, additional catheterization for 1 more week. So what is your post-operative management plan? So documentation, Meo's monitoring, instruction for catheter care by nurse specialist or midwife. Ensure that your WHO safety checklist, swab needle count, WHO safety checklist will be confirmed in question number 2, which I have not mentioned in my answer key. Okay, but we have discussed in the format of the structure discussion. So those points will be discussed there only. Neonatologist to assess the baby and encourage breastfeeding. Extra antibiotic for 7 to 10 days. Early mobilization and adequate pain relief. Continuous catheterization for 2 weeks. Catheter care by midwife and continuous nurse in primary care after discharge. This needs to be communicated to the GP surgery with the help of discharge summary. VT risk assessment accordingly, low molecular weight heparin if needed. Discharge with contraceptive advice to primary care. Clinical governance issues will be incident reporting, duty of candor, arrange debriefing by seniors, and self-reflection, reflective tasks, CBD, audit, and root cause analysis. But incident reporting and duty of candor, these are two important points which one should not forget in clinical governance point. The rest of the points, it is okay if you can mention, it is okay if you cannot mention, still it is okay. But duty of candor, incident reporting, and debriefing, these are the important points in this question. Now, what issues would you like to discuss with the patient post-operatively? So here one point I had missed out is one thing, that lay language, use of drawing. These 2 points I had missed out. Uncommon, unfortunate known complications in case of previous to LSS cases, because it is a high risk for a bladder injury because of the adhesions. And in this case, we had encountered a bladder injury. The best part was we had identified it on table, repaired by the seniors and expert involvement. Implication will be prolonged stay, catheterization, prolonged antibiotics, follow for healing, and investigations like CT uro, micturition, cystourethrogram. So she may need to investigate further. No long-term effect if healed properly, but there is a small risk of VVF. We need to investigate why this has happened and whether we could have taken extra precautions to minimize this injury. So root cause analysis, the results will be conveyed to the patient by seniors. Duty of candor, that is written apology in a open and honest way. If patient is not happy here, then we can guide her for the pulse. Arrange debriefing by senior. Discuss newborn care with the patient, breastfeeding, discuss and guide for contraception. And when to report. It is very important. Red flags, when to report, we need to explain. And when we are going to remove the catheter, that also we need to explain in this case. So with these things, we have completed the model answer key. Now coming to the, what we will say, domain wise scoring. So here it was 4 domains. No information gathering was here, basically. 4 domains, that is communication with colleague, communication with patient, applied clinical knowledge, and patient safety. So let's see. Communication with patient and families. If awake, communicate in non-frightening way, which we had communicated. Able to describe to the postnatal patient a clear action plan and rationale for follow-up based on the discussion. Able to educate the patient on bladder and catheter care, newborn care, breastfeeding, and contraception. So these all points we had discussed. So it's a clear pass. What do you think, Manika ma'am? Hello? Hello, am I audible?
Yes, ma'am. You have done everything perfectly, ma'am. We have done. You told
Okay.
about breastfeeding, contraception, everything is complete, ma'am.
Yeah. Communication with colleague, it is call for help. It is very important not to forget call for help in this situation. This way only any suspected injury go with this format only. So just remember, structure discussion is only approach. If your approach is correct, you can crack down on any structure discussion very safely. Licensing with other specialties like anesthetist, scrub nurse, consultant, and urogynecologist, neonatologist for baby care. Referral involvement of seniors whenever necessary. Involve post-op nurse in clear post-op care. Discharging letter to the GP. Involve continence nurse and catheter care. Clear agreed management plan pathway detailed in her notes and communication to the GP. So we had done this also. Patient safety. Identify the bladder injury and stop. So this stop is the buzzword. You should not forget this and call for help. Clearly informing anesthesia scrub nurse, calling the theater consultant to the theater also, because he was busy in theater office. It has been mentioned in the beginning. Okay. Involve seniors and urologist also. Consultant can decide whether urologist assistant is required or not. You cannot call upon urologist, it will be consultant decision. Consider baby delivery safely. Without extension of bladder injury, competent candidate will have a clear and coherent plan for patient, including good quality documentation. Leaving the catheter for around 7 days, catheter care with clear instructions to nursing staff to avoid if it blocking, and what is it what to do if it does. Post-operative antibiotics, documentation, debriefing, duty of candor, and DVT prophylaxis. Applied clinical knowledge, understanding the principles of such repair and its management as a two-layer approach with absorbable sutures and considering peritoneal drain to ensure there is extravasation of urine through the repair. Indwelling Foley catheter and prophylactic antibiotics. This is applied clinical knowledge. So with this, we have completed task 1. Okay.
Super revision, ma'am. Good, ma'am. Very
Thank you.
good.
Okay. Anybody